Welcome to Vein and Lymphatic University Grand Rounds. Today, we're privileged to have Dr. Michael Akesson and Professor Alan Davis and Paola Ortiz to join us in discussing Endovenous Tumescent delivery system, a game changer. My name is Lowell Kabnick, and I will be your host. We meet every week on Wednesdays at 12 o'clock, so please feel free to join us. Michael, the floor is yours. Victor, would you show the presentation?
Thank you, Lowell. Hello, everybody. And thank you, Lowell, for inviting me to this Vein and Lymphatic University Grand Round webinar. My name is Michael Akesson, and I'm an interventional radiologist, and I've been working with vascular intervention since the late 80s. Since 15 years, I'm involved in Scandinavian Venous Center, the largest private vein clinic in treating superficial vein insufficiency in Sweden. Endovenous terminal treatment is still considered to be the gold standard in superficial vein insufficiency ablation. To treat the vessel with heat, a significant fluid infiltration into the perivascular tissue around the vessel must occur, known as the tumescent. This provides pain relief, compression of the vein, and protection of the surrounding tissues from the heat. Yes, please, next. Victor, can you change image? Thank you. The anesthesia process in endoterminal treatment is done through several transcutaneous injections with the aim of finding the perivascular area around the saphenous vein. To accomplish this, experience is needed to locate the three-dimensional area by using ultrasound guidance. The procedure is considered to be difficult and time-consuming for the physician and painful for the patient, as many injections may be needed to achieve a good anesthetic effect. Next, please.
Centro Paraguayo de Varices.
Due to the challenging process involving infiltration of tumescent fluid, non-thermal, non-tumescent methods have been developed to have an alternative treatment technique that avoids these unwanted effects from tumescent infiltration. However, today's topic does not highlight these techniques, but instead we talk about endothermal technique and how we can make that better. Next, please. Various tools have been developed to facilitate and speed up the process of tumescent anesthesia. Special long needles to avoid too many punctures, an injection pump to speed up the injection time, EMLA cream on the skin, local anesthesia in the skin. Despite all this, patients find this part of the treatment the uncomfortable part. Pain scores up to 6 on a visual analog scale has been reported. The discomfort can be mild and giving a patient some sedation or analgesia. Some clinics even offer them general anesthesia. The sedation and general anesthesia are resource demanding, as you need staff to monitoring the patient and post-treatment care at the clinic. Next, please. So if the physician easily could place tumescent without pain for the patient, would that be a game changer? Next, please. The endoterminal, you can click it, the movie. The endoterminal fiber is connected to the Solutio catheter outside the patient, and the fiber is introduced into the vein, and the tumescent, the Solutio catheter glide over the fiber, and there is a needle coming out penetrating the vessel wall, and you inject the tumescent in the perivascular area. And you do this step by step. Next, please. The endoterminal fiber is connected to the Solutio tip. Please, next. The tip of the Solutio catheter. The part of that is also included a special pre-shaped needle. Next, please. The needle is controlled by the slider on the handle. Next, please. And that slider pushes the needle out and in at the Solutio catheter tip. In the distal end of the handle, not seen on the image, there is a lever lock where you can connect the tumescent syringe or a foot control pump where you can control the tumescent. I start thinking about a technique that we could facilitate the difficult process of tumescent delivery 10 years ago. This was painful for the patient, I saw, and difficult for the operator. Before going into the venous side, I've been working in the University Hospital in Malmö, doing a number of subintimal recanalization. And I saw that was almost painless for the patient, even though we now and then sometimes perforated the complete wall of the artery. And the same applies for perforation of the vein wall. So I made a technique where the vein wall was penetrated by a needle from the inside of the vessel and out into the perivascular area where we could infiltrate tumescent. After several years of technology development, laboratory tests, animal experiments, and initial human tests were done, and the Solutio catheter was born. Next, please. The Solutio safety and usability study were done after receiving approval from the Swedish Medical Agency and the Ethics Committee. Each patient consented to participate. 8 women and 1 man were included with a median age of 57 years, and the median length of the treated GSV was 41. All patients were scheduled for laser ablation at Scandinavian Venous Center in Malmö, Sweden. Pain scores were measured during tumescent deployment according to the visual analog scale. Follow-up were included in the study for 4 weeks period. The subjects were asked about complication, painkiller use, and examined for signs of bleeding and complications. Next, please. Pain scores had a median of 0.5, and it varied from 0 to 2.4, sorry. The subject with a 2.4 score reported that the pain came from the puncture site area in the lower leg, and the surgeon suspected that was caused by a dissection while accessing the vein. The PI generally considered the catheter to be safe and easy to use with a short learning curve. 2 minor device-related defects were reported: low flow in a long 90 centimeter needle, and 1 catheter with high friction while pushing the needle out of the catheter. 2 mild vein perforation were reported, not caused by the Solutio catheter, but by the laser fiber. During the 4 weeks follow-up period, no serious events were reported and no sign of bleeding were verified. All patients had a 12-month follow-up that are included in the Scandinavian Venous Center's protocol after terminal ablation. And at that time, all treated GSV were included. Next, please. So in conclusion, the Solutio catheter is feasible, safe, and associated with very low pain scores in connection with the infiltration of anesthesia. Experience from the first-in-man test ended up in a new improved catheter design. and new animal studies and a larger human study are planned and will be conducted during next year, early next year. And we hope to verify the result from the first study with this new design. Next, please. Thank you very much.
Thank you, Michael. That was very informative. I would like to go to Paola Ortiz for her comments and/or questions.
Okay, so hello, good afternoon. First of all, thank you very much for the invitation. It is truly an honor and a pleasure to be here with all of you. And congratulations, Dr. Akesson, for this study and for bringing us this new methodology, which is amazing. I think it is excellent to have a device that we can decrease the pain of the patients and make the tumescent injection less complicated. So I think the device shows like a little a good future, maybe change our future. I have some questions regarding, for example, the technique. I didn't understand some detail about the technique. When you are inserting this device through the micropuncture kit, so the same and how you inject is connected to a pump as well as like a claim pump. So the other thing is what are the mild deficiencies you find? What's a problem with injecting outside of the compartment, or what it was the problem? Because sometimes the compartment is too, the vein is completely surrounded. There is no much space where to inject, and maybe you are injecting outside of the compartment, not inside. So I think I want to know more about this, the technique. And also another thing I have been thinking is about the cost. This increases maybe the cost of the procedure. This is like disposal. You have to have in each patient a new one. So, but first, thank you very much. It's amazing, and I'm very happy to know that new future are coming for tumescent delivery system. Thank you.
Thank you. Thank you very much for good questions. The way we are planning to do this, and what we did in the first in human, was that you connect the system outside the patient, and then you go in through the introducer with them connected together. And in the introducer, you go forward with the fiber, the treatment fiber, up to the area where you want to start the treatment, like up to the SFE, for example. And then you follow with a tumescent, with the Solutio catheter, all the way up to that area. And in that area, then you use the handle and put the needle out, and you see it very well on ultrasound, and you see it penetrate the vessel wall. And then you start with, if you have a foot pump that you can control, you start the injection, and you see how it's dissect around the vessel with the ultrasound from the outside. And when you feel that it's not dissecting any longitudinal or circumference around the vessel, you bring the needle in again, and you pull the Solutio catheter backwards along the fiber, and then you find a new area where you haven't put any tumescent, and you go in with the needle again and start the pump again. That's the way that you're gonna do, yeah. And there is a talkability of the Solutio, so you can, if you see that you don't have, like there is some type of a little tumescent in one place, you can always take the needle in and then turn the handle, and then you turn the needle together with the handle, and you can go out in another direction if you want to go up or you want to go lower, like caudal, or wherever you're aiming.
Okay. Thank you.
Okay. And the second question was?
Yes, it was if you can inject outside or inside. So I think it's depending of the technique with your curve. So sometimes if your needle is this needle, I don't know how long is the needle
It's
that you
coming
are
out.
injecting.
It's coming out 80 millimeter to the side, and you can go out fully, or you can make it shorter if you want to. So
Okay,
you
so
can
it's
you
like
can
easy to handle and to inject inside of the compartment always.
yeah. You can fine tune it if you see that you have penetrate too far away from the perivascular area. You can take it slowly back and find the right position.
Okay, and the other was if you need one device for each patient, right?
Yeah. There is a cost of that, of course, but what we see here is that you can probably make more patient in the same time using this technique, because it will facilitate the treatment, so you can speed up the treatment for each patient. So and maybe you can even dress the patient less than you do today, and you can save that cost in other places, with other materials that you use.
Yes, I understand long term, and also yes, I think it's really interesting, and so you decrease the cost because you have more patient probably, and also less pain for the patient, which I think is the most important thing here. Interesting. So thank you very much.
I would personally pay for less pain.
Less pain, yes.
I do have a question before I turn it out to Professor Davis from Omar Sponda. Is there a reduction in tumescent volume applied resulting from the use of this technology? What do you think?
What we saw in this, I mean, it was 9 patients that we have tested it on, and but what we saw was that in the last patient that we had in the study, the PI used less and less tumescent, because then he found a technique how to fine tune and how to make that dissect around the vessel. So it lowered very prominent, but I can't put any figures or any
I understand.
on that. Yeah.
From your next trial, maybe. If the vein is too close to the skin, we often put tumescent anesthesia between the skin and the vein. Is the needle long enough to go through the vein wall and through the compartment to the subcutaneous tissue?
Good question. We don't want to puncture out through the skin, but I mean,
Through the compartment.
Definitely up to through the compartment. And if you put some pressure from the outside, it's I would say it's gonna be no big deal to pass through the compartment.
Fair enough. Professor Davis, the floor is yours.
Right, I've got quite a few questions that I'd like to ask you. One, and I mean, it may be because I didn't quite understand, do you segmentally put in the tumescence and treat bits and come down segmentally, or do you put the tumescence for the whole length of the vein in at the very beginning?
Today we put tumescent all the way with a number of transcutaneous puncture, and you could do the same with a tumescent with a Solutio catheter. But you can also do it stepwise, that you put one part of segmental with tumescent, and then you bring the whole system back with a So that's.
Then my next question is, with the vogue of some people thinking that we should be doing a flush crossectomy, how do you, with this technique, ensure that there is sufficient tumescence around the junction to be able to ablate all the way to the junction if you believe in doing it as a flush crossectomy?
Of course, you have the ultrasound guidance, and you can always put fiber down into the junction, so you can be sure that you go all the way up with a Solutio catheter all the way up to the junction.
And my next question is, does the size of the vein that you're treating have any influence on the use of the technology?
I mean, a large vein, if you put the patient in Trendelenburg, that will shrink together, and if you put some compression from the outside with a transducer of the ultrasound, I don't see that there will be a problem coming through the vessel wall, that the vein is too large. No.
Okay, and I've only got two more questions. One, do you think treating the short/small saphenous vein will be any different from treating the GSV?
No.
And then my other question is, and obviously this will depend on your conceptual idea of management. What do you think will be the implications for people using this technology for how they go and treat the tributary veins?
I think it could be like this, that if you want to have the treatment like almost pain-free, you use the Solutio technique, and you wait to make some phlebectomy, or maybe wait for some couple of weeks, a month, and then do the phlebectomy if necessary.
Okay. And what do you think, and it is a third question, do you think this technology, if adapted, would be particularly useful for perforator intervention with some adaptation?
Perforators are very short, and I think that perforators maybe is better to put tumescent with transcutaneous injections.
Okay, Lowell, thanks very much. Thank you very
Thank
much
you.
for answering my questions.
Thank
So,
you.
Michael and to Paola and Alan, I think that this particular device is going to be used for truncal ablation. I do believe that if we are going up to the junction, that we know that the compartment is septated a little bit, but that in my experience, having given quite a bit of tumescent anesthesia into the compartment, I was never able to raise the pressure. So we do know that it's fairly open, Alan, from ankle to foot, with certain areas where there are ligaments that attach, but still it's open. So I'm not concerned about the junction if we were going to do flush ligation. The one question that is at hand, and I think you alluded to it, was total laser ablation, which people are doing now, where they are treating the varicose tributaries with laser as well. And I think, Michael, I think you solved that question as to do percutaneous there. In terms
Yeah.
of potential changes, I know that there are some potential changes to the catheter that are coming, which eventually you'll be able to talk about, but I think it'll make it that much easier going forward. Any further questions, Paola, Alan, or comments, Michael?
No.
Not now.
Just as a question, as there is time, Lowell,
There is.
do you think, and I understand it may sound like a silly question, but do you think your ecchymosis rate will be higher using this technology than other things?
No, I don't think that. No.
Did you see that in the trial?
No.
But from a theoretical point of view, Alan, I understand your question, because with the microperforations that we saw with laser, that did add to some of the inflammation and the ecchymosis. But that's something that if you've not seen it, that's great. Any others? If not, I'd like to thank everybody. Remember, we are also broadcasting on YouTube. Next time we will be absent this coming Wednesday as a result of the VEITH program in New York, which a lot of us will be attending. And on the 26th of November, we'll be talking about how to avoid complications of glue, tips and tricks. The main speaker will be Dr. Kathy Gibson. Dr. Demetrius Kathanasis will be a discussant, and Professor Nuttawet will also be a discussant. So we look forward to seeing you there, and thank you for joining us. And thank you, everybody that joined.
Thank
We'll see you
you.
next.
Thank you very much for the invitation.
Thank you for the invitation. Yes.
Mm.